questions from all of this. You know, obviously we're not gonna give you 50 practice questions. It is a comprehensive course, so I know it's a lot of material. Some of the ways to look at it are like easy ways to differentiate things, like when we were talking about like that tumor that has Warner syndrome with it, things like that are easily identifiable, or things, you know, are ways to kind of help break down some of this. There will be some pretty, you know, a lot of basic questions with imaging, but we'll try to cover most of the stuff that's going to be on the test. Obviously, we're not doing a test review because then it's like, okay, here's 50 things that, and then it's super broad, and you almost got to tear apart your material, and it's not as helpful. But anybody have any questions before we get going? All right, we'll start with thoracic disease, which is where we initially started this lecture series. So you got a 57-year-old, got a 3-week history, non-productive cough, no weight loss, hemoptysis or night sweats. What do you guys want to know about this patient? Yeah, is he a smoker? Good. What else?
Any other symptoms? What's going on with this person?
Yeah, so, yep, those are all good. Obviously, like, do they have any smoking history, travel history, any like history of cancer? What sort of past medical history do they have?
Are they on an ACE?
Maybe. We'll see in a second. He's on one of them. All right, so he's got a past medical history. He's got hypertension, unabated blocker, 25-pack year smoking history. What do we think we're going to see on physical exam? Good. Yeah, possibly. Yeah, right. And what does that indicate? Some sort of COPD. Okay. And then, like, obviously, you know, a cardiac exam is important, pulmonary exam, and then like a peripheral nerve exam as well. He does have a 25-pack year smoking history. He does have hypertension. He's got a lot of risk factors for other conditions he might have, but he's presenting with 3-week history and non-productive cough. So on exam, he's afebrile, you know, completely normal findings on exam. What is the most appropriate next study you guys want to do for this patient? Yeah, chest x-ray, so start simple. All right, so we got a chest x-ray on him. What do we see? So he's got a mass in there. It's, you know, not extremely obvious, but everybody see where it is? It's got like right there, you can kind of see there's a mass. You can also see up here, it's something going on with the hilum. We don't know exactly what, but it looks different than it normally should. So like, yep, you got a lesion here, you can kind of see that line. It's kind of round, subtle, but it's there. And then this is like, it's an enlarged hilum. It's kind of non-specific. We have a previous chest x-ray, which is always helpful if we have some prior imaging we can look at with the patient. So, I mean, does it look the same or different from the previous one? Different. Yeah, it looks different, right? So, yeah, like I was saying, you can kind of see it, oh, right there. And then he's got some like hilar enlargement as well. Does it look like probably some emphysematous changes on here? Yeah. All right, so there's a positive arrow sign, which is always good. So yeah, he's got a mass there. They measure it at like 2.5 centimeters. Like a right paratracheal mass or right lower paratracheal mass. All right. Now, what if this was like a young, thin male patient? What do you guys see on here? Yeah, pneumothorax. Yeah, right side. So you can see that like the visceral pleural line like we talk about. I don't know why we always have like really bad images for the pneumothorax. Maybe because they're so obvious a lot of times. We're like, all right, let's just Let's get the crappiest one image we can find. What are we gonna do for this guy? Poor gal. Chest tube? Is that what I heard? Yeah. So what else do we see in this X-ray? Do we see like any tension physiology? No? Yeah, I don't see any, right? It looks midline. I mean, it doesn't look like it's causing tension physiology. So yeah, this patient's gonna need a chest tube. If we have tension physiology, then, it depends on how emergent the situation is. Typically in a trauma room, look at a chest tube. You can sometimes do like a needle decompression prior to. However, definitive treatment, they need a chest tube. All right. What do we see on this X-ray? And he's got like, history of fever, night sweats, weight loss, cough. What is that? What does it look like? We got air fluid level. Yeah, everybody seen that on there? So, and we got a classic air fluid level. So that's a lung abscess on that patient. Usually they present with some sort of like constitutional type symptoms. Usually we'll have a cough, fever, might have night sweats. The question is, what type of patient is this? Is this like a young, healthy patient? Is this an elderly patient? Is this like an alcoholic patient? Those are all things we need to think about when we're treating these, but this is a lung abscess. And what's the treatment for it? Yeah, antibiotics. Good. All right. Now what if you get this X-ray? Yeah, he's got, some sort of, probably an empyema, but how do we diagnose that? Yeah, we need a thoracentesis on this patient. So let's say you got, an elevated protein count, a low glucose count, and like a pH of 7. What are we thinking? What was that? Yeah, exudate. Yep, some sort of exudate. Good. So what is the treatment for this? We're going to get a thoracentesis, yep, and that's how we'll identify what it is. So what if you have this patient, you've treated him with antibiotics, you're not seeing any improvement, and he presents again with, the same findings on chest X-ray. What is the next study you guys are going to do? Yeah, CT of the chest. Good. All right, and then what if you draw the fluid off and it's white and you see fat globules, chylomicrons? What is that? Yeah, chylothorax. Okay. Good. All right. So you got the chest X-rays, got that soft tissue density, the perihilar region on the right. All right. So what are our next steps for this patient? Original 57-year-old. He's got a non-productive cough, 3-week history. Yeah, CT is a reasonable next study we can do for this patient. And that's going to be the best study, obviously, if we're looking for any sort of like solitary lesion in the lung. That's going to be like our gold standard in that chest CT. So yeah, this was a 57-year-old male. He was a smoker, non-productive cough. He had a solitary nodule, suspicious for malignancy. So yeah, we want to get a CT of the chest to better identify that lesion. And based on those findings, we may need to get a bronchoscopy with or without biopsies, probably with biopsies. We can also do a CT guided biopsy or like thoracoscopic resection, but we need some sort of definitive pathology report on this patient. So, any one of those will be sufficient, and it's all just location and patient dependent. Probably the least invasive is going to be like our bronchoscopy with or without the brushings and washings. All right, so this patient, obviously, we need to screen them for lung cancer. This will be something you guys commonly see, like what? You're just, any smokers, typically over the age of 50, you're getting a chest X-ray annually, especially with this patient, since 25 pack year history. That's an important test we're gonna annually screen for, and I think that's USPSTF guidelines as well. All right, so the solitary nodule, typically our first test like we did was get a chest x-ray on them. Typically presents with non-small cell lung cancer. And then we gotta look at whether they have a presence of a cough or any other non-specific symptoms that might be related to it. Like what was like what if he had, you know, if they had meiosis and ptosis, what kind of lung cancer would we be thinking about? Yeah, like a Pancoast tumor. So where does that present on chest x-ray? Yeah, the apex is. Good. All right. So typically with these patients, we might monitor them for stability, especially if they're asymptomatic or relatively asymptomatic. They usually get a chest x-ray annually. We'll get a CT scan, and we'll continuously monitor them to check for any changes in a lesion size, and we'll look for any characteristics of any sort of cancer or malignancy, like that. You know, obviously it doesn't have like clear borders. It could have some sort of calcification. All right. So what other conditions might be associated with the different types of lung cancer? Like, what else might we see if we're talking about lab-wise and other things? What might we be worried about? What was that? I mean, yeah, alk-phos is definitely a good one, especially when we're drawing that fluid from it. What about like, if we're looking at like ADH? Sometimes these patients will have SIADH, so we'll want to look at their sodium levels as well, and we can draw and take a look. So they might be suffering from an SIADH. All right, so you got a 45-year-old non-smoker. He's got a 2-centimeter soft tissue mass in the left lung field. What's the most appropriate next step for this patient? What do we want to look at here? Yeah, we want to look at priors, right? So we want to compare for stability. You know, is that lesion growing? Is it staying the same size? Is there any changes in it? Are they now symptomatic? So this patient likely, you know, we'll get a chest x-ray compared to previous and observe them. If there's no changes, now if there's changes, then we need to look at possibly doing CT scan to further evaluate, and then a general surgery referral for some sort of biopsy versus resection. All right. So this is, you got the, you know, same patient. They order a CT scan of the chest, which identifies a peripheral apical lesion, which we just talked about what those can be. What might they present with, like physical exam findings? Like Horner syndrome, yep, good. Good, yeah, so this one's gonna need a bronchoscopy with a biopsy of the mass. What other symptoms can these type of lesions cause? Yeah, like compressive type symptoms, yep. So you can get like your Pancoast syndrome, you get compressive symptoms. Might have, you know, it could affect the recurrent laryngeal nerve, so they could have, you know, some sort of hoarseness. It can affect the phrenic nerve, so they can have trouble breathing. All right, so 53-year-old with a 20-pack year smoking history, 2 weeks of productive cough, you got a right middle lobe infiltrate. What's the most appropriate management for this patient? What are some differentiators we see in there that might help us? Yeah, he's got a productive cough, right? So we're likely thinking maybe something is more acute in this patient. So they're likely going to need antibiotic therapy for pneumonia. followed by a repeat chest x-ray, which we typically recommend like 4 to 6 weeks after treatment in all of your pneumonia patients. And then if it persists, we'll get a CT of the chest and possibly a bronchoscopy, depending on what we find there. What if this same patient presented and he's got a pleural effusion there? What do we do for that? What's our first treatment? Let's say we got a chest x-ray and we got a pleural effusion. So what is it? Yeah, thoracentesis, so we want to drain it. We want to run samples on it. Good. All right, let's go to the next one here. What questions do you guys have on thoracic disease? You guys all think you can find a lung abscess and pneumonia on a chest x-ray? Everybody feel comfortable? Or do you need like a positive arrow sign? You probably need a positive arrow sign, yeah. Not wrong. All right, let's move into the, we'll go into vascular disease. AAA, everybody's favorite. All right, so you're doing a routine physical exam. You identify an asymptomatic pulsatile mass in a 62-year-old male. What sort of medical history do you want to know? Yep, smoking's a big one. Good. Any history of like hypertension, hyperlipidemia? Good. What about family history? That's probably important. Like your risk is elevated with family history of AAA, so it does portend like a higher risk for them to develop a AAA. Good. All right. So his medical history, he's got hypertension, stable angina, 40-pack year history. Like how many cigarettes is that a day? 40-pack year? That's a lot. All right, his current medication is on a beta blocker nitrates. He says he's active, golfs twice a week. What are we going to look for in a physical exam? Like pulse style mass, obviously. We want to do a good cardiac exam. We probably want to listen for any bruits. We want to do like a peripheral vascular exam as well. We want to check those lower extremities and ensure he's getting circulation. It's equal bilaterally. So on exam, carotid pulses and extremity pulses are normal. Abdomen's not tender. Pulses of the femoral and popliteal regions are readily palpable and appear more prominent than usual. What's the best test we can do for this, or what's the initial diagnostic study? Yeah, abdominal ultrasound, right? It's easy, it's non-invasive, doesn't expose them to any radiation, so we get an ultrasound. Now let's see what the ultrasound says. So you got a 4.8 centimeter aneurysm in the infrarenal aorta. Is that good, bad? What does that mean? 4.8. Do we need to take it out right now? No. Or not take it out, but do we need to fix it right now? Or do we need endovascular repair? No, probably not. Especially if he's asymptomatic, we don't. What sort of complications can they have from this? What's our most deadly? Obviously rupture, okay. What about, what else can you see with this? Yep, fistulas, right? So what sort of fistulas might we see if this if it erodes into the inferior vena cava or communicates with the inferior vena cava, what might we see? Like a high output heart failure, yeah, good. Yep, so you might get CHF. What about if it erodes into the duodenum? Yeah, you can see an aortoenteric fistula. What might they present with? Say they had some vomiting, they might have some GI bleeding. So they might have, either hematochezia, they might have hematemesis, might have just dark tarry stools. And then so let's say we don't have any of that. What are we going to do for this guy next? Yeah, monitor, right? How often? Every 6 months. And then what if it grew, like what sort of sizes are we worried about over that 6 months? Yeah, half a centimeter, good, and a centimeter in a year. All right, so here's a summary. We had a 62-year-old asymptomatic AAA, 4.8 centimeters. Obviously, we worry about ruptured AAA, any sort of thrombosis, emboli, arterial aneurysms. So for him, we're going to continue surveillance since he's asymptomatic. It's not over 5.5 centimeters yet, which is typically when we recommend vascular surgery. And then what type of repair do we normally do for these? Yeah, endovascular aneurysm repair has the best survival. Good. What size do we repair that? Yeah, over 5.5, good. And then is that, if he's asymptomatic, it's over 5.5, is that like an emergent surgical referral? Elective, right? Good. All right, so you still got the same patient. Obviously, like we said, it's best to follow this patient. What else might we want to monitor on physical exam for this patient? What's that? Yeah, we want to do obviously a peripheral vascular exam, neurovascular exam. We want to do an ophthalmic exam as well, looking for any of those like Hollenhorst plaques. Good. All right, now we got some imaging here. What do we see on this? Yeah, you got a pretty large aneurysm, right? And it looks like there's, well, we don't see any like blood collection, like where it would be dissected in there. We do have the large aneurysm. It looks like there's still blood flow distal. It looks pretty large though. I think that one's bigger than 4.8 centimeters. All right, what is this? Yeah, where's it at? Yeah, it's thoracic. Yeah, it looks like a thoracic aortic dissection. Probably looks like the descending aorta. So what are you going to do for this guy? What's that? Yeah, this one, it depends on if he's symptomatic or not. So let's say you got a chest x-ray at a wide mediastinum and he's hypertensive. What's your treatment choice? Yeah, some sort of beta blocker. We want to control that blood pressure acutely. And then if it's stable enough, we'll get a CT scan like we've gotten on here. What other tests can we do to evaluate that? Like it's better, more for like ascending aorta. Yeah, like a TEE, right? So transesophageal ultrasound, so that's going to be down their esophagus, so it's a little bit more invasive. And what's a good beta blocker we like to use, like fast on, fast off? Esmolol, good. All right. So here's our patient again. He was diagnosed with a AAA. Obviously, we monitor it every 6 months for any increase in size. Anything over 0.5 centimeter, that's an increased risk. So we're going to, likely recommend them to the vascular surgeon. Or if it's over 1 centimeter in a year, or any rapid growth that we identify. And then if they're symptomatic, then that's emergent vascular repair on that patient. All right, you got a 61-year-old man is found on physical exam to have asymptomatic AAA. Ultrasound reveals 4 centimeter AAA. What's the best surveillance strategy for this patient? Of the options we have. Yeah, it's going to be D, right? Good. All right, so same patient from the previous question. When is non-op treatment most reasonable? Or when is continued not on treatment most reasonable? Which one? Who says A? What was the original size? 4 centimeter, right? So probably not A. B's growth for over 2 years. Yeah, C is going to be the correct answer. Or, sorry, yeah, C is going to be the correct answer on this one. Obviously, that's less than, it's a centimeter, less than a centimeter over 3 years. It's like 0.9. Good. What if he presented with like blue toe syndrome at this point? Is that indication for repair at that point? Yeah, that's going to be an indication for repair. All right. What do we think here? Which of the following is a known complication? So it could be more than one, right? Yeah, it could be C. Yep, definitely C. And then it could also be E as well if we have like an aortoenteric fistula. Yeah, so if they have any of that hematochezia, we need to think about aortoenteric fistula. How would we differentiate if he had hematochezia between like acute mesenteric ischemia versus chronic versus colonic ischemia? What test would we want to do? Like CT, yep. CT with contrast. Typically a CT angiogram would be the best one to differentiate. What if this, what is your guys' treatment? Let's say a patient presented with unilateral, like upper extremity, like neurovascular changes. You've got weak pulses. He's, that limb appears hypoxic. They've got decreased, like sensation of light touch. What are you guys concerned about for that? What was it? I mean, probably like an acute, complete occlusion of that vessel would be the biggest concern there. And what do we do to treat that, or what can we do initially to treat that? They're probably going to need some endovascular repair, but what can we do acutely? Like heparin, right? We can anticoagulate them. Good. What does the subclavian steel present with? It's going to be like unilateral. What causes that? Yeah, that narrow. Yep. Good. All right. All right. What questions you guys have on aneurysm? Other than what's the test question? That's pretty much it. All right, let's talk about thyroid, some endo stuff. Everybody's favorite, right? All right, so you got a 23-year-old female. She has asymptomatic neck mass that was found during a practice head and neck exam performed by a fellow med student. Have you guys palpated any like abnormal exams on each other? Anybody like real worried about anything? No. I know they found like cancer in somebody one year in PA school. Got diagnosed from a physical exam. All right, what do you want to know about this patient? So you got an asymptomatic neck mass. What are your questions?
Thyroid level.
Yep, good. Yeah, you want to know like any history, any hyperthyroid type symptoms or hypothyroid type symptoms. Good. You want to know, did they have any history? Probably not if she's 23, but any history of like neck irradiation. Just because that can increase their cancer risk. What else do you want to know? Yeah, right. So family history is important at this point. Do they have any relatives with thyroid disease or thyroid cancer? Any history of like MEN in their family? Good. Alright, so she denies symptoms of hypothyroidism, no exposure to radiation, no family history of thyroid disease. What do we expect to find on physical exam?